everybody. Good afternoon. Thank you for being here. This is the first time I've been to Barnsley. Is anybody else first time here also? Absolutely gorgeous. Did not even know this gym existed, but I do now, so it's a good thing. My name is Michelle Wallace. I am the Chief Nursing Officer for Grady Health System. Been there for about 10 years. I'm an ER trauma critical care nurse by background. So this has always been my baby, is working with trauma. And so I'm also one of the commission members. I just started that about a little bit over a year ago. And today is our first real in-person. I know there was some in-person folks that met in August of last year, right as we were entering our fourth COVID wave. But this is our first real one where everybody has the opportunity to be here. So before we get started, I would like to just do quick introductions of the room. So just your name and what your role is and then which health system you're representing. So we'll start over here.
Hey, Raina Roberts. I'm the Director of Trauma at Children's Healthcare. Patrice Walker. I'm the Chief Medical Officer at Atrium Health Navigation.
Stephen Sherlock. I'm Director of Critical Care Services and Respiratory, representing Archibald Memorial Hospital in Thomasville, Georgia.
I'm Amy Watson. I'm from Effingham Health System. I am the ER Director, Trauma Program Manager, and now Clinical Lead. Standing in for administrator.
I'm Dr. Julie Barnes. I'm Chief Medical Officer at Redmond in Rome.
Jeffrey Harden, I'm the Chief Nursing Officer for Memorial Health Meadows in Muddy.
And Jane Lynn, Hamilton Medical Center, Chief Nursing Officer.
I'm Dr. Brian Glassman. I'm the Chief Medical Officer for Hamilton Healthcare System.
I'm Jessica Story. I'm with Warren Averett. I'm the accounting firm that validates uncompensated care and the readiness cost data.
I'm Marty Wynn. I'm the Chief Financial Officer at Piedmont Boston.
Tom Castillo, CEO of Marty Medical Center.
Steve McCary, Executive Director of Patient Services at Piedmont Athens.
Sheila Bennett, Atrium Health Floyd, I'm the Chief of Patient Services.
Tiffany Howard, Hospital Administrator and CNO for Atrium Health. April Dukes, Chief Nursing Officer at Chris Regional.
I'm Ashley Bullington. I'm the Trauma Program Manager at Chris Regional. And I'm Alicia Register. I'm the Trauma Medical Director at Chris Regional.
I'm Angela Gary. I'm the Executive Director of Trauma and Emergency Services.
Vice President of Trauma at Travis Hospital.
Debbie Mitchell, President and CEO of Moretown Clinic.
I'm the Director of Finance, Northern Gwinnett.
Stacey Howard, Chief Operating Officer at Fairview Park Hospital at Dublin.
Lynn Grant, Trauma Program Director from the Fairview.
I'm Katrina Kiefer. I'm the Chief Executive Officer at Augusta University Health.
David Hoffenberg. I'm the Chief Operating Officer at Memorial Health in Sedan.
And I'm Damian Scott. I'm the CEO at Manual Medical Center in Swainsboro, Georgia.
In case you don't know me, Liz Atkins, Executive Director, Georgia Trauma Commission.
Dennis Ashley, Atrium Health Madison.
And on the wall.
Oh, I was looking that way. Cheryl Ward, I'm with Georgia Trauma Foundation.
Chief Nursing Officer at Piedmont Clinic.
Hi, this is Cindy, AVP for Wellstar Trauma Services.
Hi, Lindsay Petrini. I'm the Chief Operating Officer at Wellstar Norfolk Hospital in Roswell.
I'm Kristen Bowman. I'm Chief Operating Officer at Wellstar Common Hospital in Roswell, Georgia. I'm Regina Medeiros. I'm the Trauma Program Director at Augusta University and also a commission member. Gary Page, Trauma Coordinator for Memorial Health Meadows.
Renee Morgan, Trauma Program Director. Gordon Fuller, with various management.
Carrie Manfield, Burn Program Manager at Creed.
Welcome. That's quite a group in here. Let me tell you, this is great participation. So thank you. Really just going to take just a couple of minutes because I want Dr. Ashley to be able to have a bulk of the time to discuss readiness today to understand our purpose and impact. So we are a subcommittee of the Trauma Commission, and our main purpose is consultative. Throughout the years, we've had a as you've seen today, very strong contingent of our trauma medical directors, as well as our trauma program managers and directors. And really the arm that was missing was those of us in this room to really bring our expertise to the team to be able to clearly help guide and consult with the commission, really focused around 3 areas: quality, access, and finance, with finance being probably the first area of priority that we really need to focus on within this group. You know, over the last couple of years, COVID has impacted, but the healthcare landscape has shifted as we look at revenues, supplies, staffing, case mix index, all of those things that have shifted. But what has not shifted is the care of the trauma patient. That volume has increased. We are not able to stop trauma unless you go on diversion. Even then, it doesn't work. We've not been able to cancel trauma. So when we think about elective surgeries and things of those nature, all the work that happened during COVID to help us stop that volume did not happen during trauma. And I think that's important because every single one of us in this room serves as a safety net for that population, for those groups of patients who really need the expert care that we provide, that you lead in each of your institutions. So it really is that important for us to make sure that we keep moving trauma forward. And for the Trauma Commission, one of those big components of that is our finance. Readiness cost is probably the most important thing right now. As you heard, great overview this morning, a little bit about that. So if you haven't had a chance to read that article, please read it. It really is a great understanding of what our role is as at individual centers. So I'm not going to go into too much more detail because I really want Ashley to have the time to share our readiness costs and for you all to clearly understand that. We will come back at the end to talk about next steps and what that needs to look like from those of us in this room. So thank you for your time today. I know it's a lot to get away. There's a lot going on within your centers, but we really do appreciate your attendance and just your great work that you've done while you're here. Thank you.
And I hope you guys picked up some of our annual reports that we had on the tables out there. We have plenty more where those came from, but it really is a direct reflection of the work that you and your teams have done. And so it's really, that's really for you guys to celebrate. So take it away, sir.
I'd like to echo Michelle's comments from the Trauma Commission. As I said earlier, this group is really one of the priorities for us for next year. And the reason I say that is because we never had this much participation before from our executive team. And the commission really needs that input. We have EMS committees, we have trauma program manager committees or GCTE. We really have a lot of reach out there to get information back from what's going on in the state, but we really have to have input from you guys. And so this is very important. And so thank you for being here. It means a lot. What I'm going to do today is really there's too much really for one meeting as we started looking at this. So a few of the things on the agenda we're going to have to table for another time. What I'm really going to focus on now is really just the readiness costs. And you may say, well, that's sort of boring. Why I need to know that? You know, we get some money and let's not worry about it. But as you saw from the presentation this morning from TCAA, there's a silo of the financial executive team that's really good, really sharp. There's a silo over here, the clinical team, the trauma director, the trauma program manager, and they're really good, but they don't all the time line up to where you can go to the next level or reach the top of the pyramid financially. And so that's understanding this and piecing all these things together will make us all stronger. So I'm going to do a deep dive into this. Your brain's going to hurt a little bit after this talk. I'm going to move pretty quickly. If you don't, and unfortunately, I've got a lot of numbers. This is like going to math school again. So I'm going to throw a lot of things up here. If you can't see it, it's very informal. Just say, I can't see it. I don't know what you're talking about, or you blew by that too fast, and just focus on it. And I want you to ask questions so it can be interactive. And the reason this is important because we need to all be on the same team as we go to the next level where we look at even increased sustainable funding. As I talked about, we have to go as a united front. That's going to take everybody on the financial side, the clinical side, all institutions working together. So again, please interrupt if you will. So here we go. Water Trauma Center readiness call. So it means a lot of different things to different people, but this is what it means to the American College of Surgeons. Cost incurred before the first patient is sent to treatment. Non-patient care costs, which the hospital would not have to pay if it were not a trauma center. So this is not a 4x4. This is not a service render. This is something that you have to have in place that you're certified as a trauma center before you open the doors, okay? Costs required by trauma center regulation by the American College of Surgeons to maintain that certification or verification. There's not much in the literature. If you Google this, you look it up, this paper was from 1999. That's a long time ago. It's from Florida. And they surveyed 20 verified Florida level 1 and level 2 trauma centers. There was 10 hospitals that responded, so not a great response rate, but for a survey, 50% is actually pretty good, as you know. They focused on these categories: physician on-call coverage, verification, administration, outreach, and prevention. And what they found was that the median cost, remember, this is 1999, readiness costs for each trauma center, 1 and 2, and they averaged together, which is, probably shouldn't do, but anyway, was $2.7 million annually. And the majority of costs was physician compensation for on-call coverage of about 2.1 million. So, if you're trying to cover a trauma center, a lot of your cost is that on-call readiness, having those teams in place ready to go 24/7. This is what was really interesting in that paper, probably one of the most, at least for us, for the Trauma Commission, as we dove into this. They noted the answers required some judgment by the respondents and considerable effort. Very difficult to fill out a financial survey based on cost. Well, how much do we charge for this? How much do you allow for this? Very complicated, almost like doing your tax returns, although with the folks in this room, that might be easy for you. As a trauma surgeon, it's not that easy. So I live in a different world. So the commission started to look at this and see if, how could we get a hold of Georgia and figure out what was going on? Because our job was to oversee distribution of funds, one of our tasks. So the purpose of our survey was to make this a more precise process, to put a border around these questions to where you couldn't get outside the box, and that you had to answer it within a certain way, and that we all did it the same way. If one center doesn't do it differently than others, we took out the interpretation aspect of it and tried to make it more scientific to where you had to be very rigid with your answers. And we looked at level 1 and level 2 centers, and we split those out. We did not combine each center. So we had to develop consensus for readiness cost definitions. We convened a readiness cost subcommittee. We developed a survey tool. Once we thought we had a tool that we could all agree on, and really this tool was based on if it was in the American College of Surgeons requirements, then it was a cost. It was considered a readiness cost. Not like, well, I have one of these and one of these. No, it has to be in the dictionary. It has to be in the ACS booklet as a requirement for you to count as a cost. And then we had a webinar with our trauma centers to discuss the proposed definitions that we came up with. And then after everybody had a chance to work on that and understand it, then we actually had a face-to-face meeting, just like this one, where we had each center sent their CFO or their designee, the trauma medical director, and the trauma program manager, and we all got in a room like this, and we went through line by line the requirements, and we set guidelines on what you could consider an expense and so on. So we put real definitions in with each line so that there really wasn't a lot of interpretation. And again, that as I presented it at the AAST, that doesn't mean that Arkansas has to do it that way or California has to do it that way, but this is the way Georgia agreed to do it. And what we did, we all agreed to do it the same way. So that was what was so nice about this study. And so this was the first publication. You see, this came out in 2011. This was our first survey. And the average annual readiness cost for a 1 was 6.8 million. Average annual readiness cost for a 2 was 2.3 million. Again, that was back in 2011. There was limitations to that study though. Even though we tried to control for things, it was self-reporting by each trauma center and there was no validation. In other words, if you read the survey and you filled it out and sent it in, we just took that as gospel and we made the tables and that's where we went to. But we thought, what would happen if we did an evaluation, a financial evaluation or validation of that data and looked at some cost components and made sure that they were appropriate and they were correct? That would strengthen our data. And then about that time in 2014, you see, we went from the green book to the Orange Book. That was just the new guidelines in 2014. So there were some extra things that the American College of Surgeons put in there, so our data was a little bit dated. So then we redid the study. I won't walk through all this because I know you'll have trouble seeing the fine print. But in general, we pulled the team together again, we pulled all the centers together again, we worked on the methodology, updated the survey to go with the new book, the new requirements. And then you see over here to the right, validation process. At this time, you can see, we asked the centers, working with Jessica back there from Warren Averett, that works for the uncompensated care for the Trauma Commission. We asked, what can we do to validate the data? And we were told by analysis or financial rules that we could pick 5 cost components for each level 1 and 4 cost components for each level 2, and then evaluate that data and really scrub it and look at it and make sure, and it would go back and forth between the centers and between the accounting firm to make sure everything was validated. And we felt this added great strength to our data. So here's the take-home message. Here's the summary. Again, I don't know if you can see this, but I'll call it out for the folks in the back of the room. But again, this is the overall take-home global picture. You can see we broke it down into categories of administration, administrative, program support, clinical medical staff, in-house OR availability, and education and outreach. Sort of similar to the Florida paper. And the mean for level 1 in the administrative category or program support staff was 3.5 million for a 1, 1.3 million for 2. Clinical medical staff, this is on-call medical staff just for trauma. And again, this is not when you're down there, the neurosurgeons covering back, a back abscess or a take back from an elective neck operation or something. This is purely trauma. We really weeded all that out. This is very conservative controlled data. 5.5 million for level 1 and 3.1 million for level 2. In-house OR availability, 830,000 for a 1, 250,000 for a 2. And finally, education and outreach. Not a lot of dollars in that, as I said earlier. Trauma centers just don't have money. They were mandated to do these things, but we do less of this because we just don't have the dollars for it. So this gives us something to advocate for at the Capitol. We need more funding in these areas. And then the take-home message of this paper was 10 million for a 1, if you want to stick a number in your head, if you're a numbers person, 4.9 or 5 million for a 2. Now we're going to walk through, just quickly drill down into each section and let you see what the cost drivers are in those sections. So let's take administrative first. Again, I know a lot of data, but I'm going to focus you into just some key points off the slide. You can look at the paper and get all the nuances. But the trauma program manager, not unexpectedly, was the most the cost driver in this category, which is fully dedicated to the trauma program. And then if we move on into program support staff, this is things like physical therapy, occupational therapy, speech therapy, and so on. Here are the key drivers here: case management, physical therapy, occupational therapy, and speech therapy. And I don't know if you can read it, but it's about, for case management, about the mean for a level 1 is about 638,000, physical therapy about 650,000, occupational therapy 590, speech therapy 590, all within a ballpark. And again, this is adjusted. This is really adjusted for trauma. Okay, this is not your total cost for other things. And then if you look at the level 2s, they're about a third of that, maybe a third to a half. You can see about 230,000 to 250,000 for these. So these are your major cost drivers for your trauma center for the program support staff. Now getting into medical staff, you can see for trauma surgery, you've got all these different surgical specialties you have to have, even some medical, like critical care medicine, radiology, and so on. These are all the specialists you have to have. And again, without being able to go into each one, here are the key drivers here: the trauma surgery, the trauma surgeons, performing, trauma surgery and acute care surgery, 1.3 million for level 1, 1 million for level 2, orthopedics, about $1 million for level 1, 718,000 for level 2, and then neurosurgery, 539,000 for a 1 versus 326,000 for a 2. And these again are related directly to trauma. So outreach and education costs. The emergency department, as you would probably expect, they had the highest cost here. The mean for a 1 was about 20,000, although really not very much in the scope of things. And then a level 2 was about 45,000 for education, departmental staff. It's interesting that the 2s were a little higher actually there than the 1s as far as the mean. And then injury prevention. This is interesting. For the level 1s, we're spending about 31,000 for injury prevention. The level 2s only 15. Really not a lot of expenditures on injury prevention. If you see it, I don't know if you can see up here, the totals, 340,000. Now think about that. Injury prevention, and I've rang this bell at the Capitol for more funding, $340,000 by all the trauma centers for injury prevention in the state. That's pathetic. That's pathetic. But we're doing the best we can. You can't think about injury prevention when you're down there, trying to save lives in the ER and have all the teams ready to go. We have to have more funding to make the system work. Community outreach, again, about 20,000 for a 1, 5,000 for a 2. Again, pitiful. Community outreach, only 185,000, working with our communities with trauma education and outreach programs. And then this is just the TMD, the trauma program manager, the folks that you have in the hospital that have to have CME and to maintain their credentials. That's what this slide shows. And you can see here, not pretty standard cost, TMD, $4,000 a year for CME, trauma program managers, a little over almost 4,000. Level 2s, a little less, maybe half as much. Not exorbitant costs, but it all adds up if you're trying to pay the bills and you're trying to send your folks for CME and help them maintain their certification, especially if they're employed positions.
Dr. Ashley, can you go back to that? Do you mind going back to that previous slide? There was another.
This one here?
Yeah, the outline hospital education. That one sort of surprised me.
In the middle.
Yeah.
Right,
Yeah.
Yeah, so.
25,000.
Yeah, that's not for the whole state. That's it. That's not a lot. And, as we talked today, you saw all the different things we're trying to reach out and be inclusive and do. A lot of that is talking to our other hospitals, especially the level 1s, reaching out and providing resources and trying to help in the level 2s in the community. And you see, there's not a lot of that going on, at least spending money on it. Good point. Was that, you want to make another comment with that?
No, I think it speaks for itself.
Speaks for itself.
But it does make me wonder. I mean, I would imagine patients benefit, but do the level 1s and 2s benefit from the 3s, 4s, and other non-designated trauma centers doing a really good job and preparing that patient for that next level of care? I would think it does.
Absolutely.
And so then I would think then that money should be spent. In one sense, I think that, but I also think these initiatives should be rural driven and urban supported or level 1 supported, not level 1 driven.
No, absolutely. And that's why I think the rural committee and the level 3, level 4 is so important, because we've never had that until just here recently. We've never had that feedback coming up to the commission to dispense out to all the 1s and 2s, like what's the need? Because your all's needs are different than our needs. And so that's why that's so important. And we're excited about that committee. You're absolutely right. It should come from you all, and then we can turn it around and pulse that out. But we've got to have more funding. That's got to go up from $25,000. And remember, we ask people to fill this out. Don't fudge it. Don't put something down there. Don't be afraid to put a 0. Remember, this is what you're doing in real time. If you didn't spend money on it, put a 0, because we don't want you to inflate the numbers. This is true data, what people are spending. Doesn't mean they shouldn't be spending more, but it's what they're spending now, and we have to increase those dollars. Yes, sir.
At least I'm looking at that saying, well, I know I have a full-time person doing exactly that. So we may have like miscategorized it in community outreach or something. So maybe it may be worth us speaking at that, because I don't want the commission to think that there isn't any resources being committed out. We may have just not, because we have a full-time person whose sole job is EMS and outreach education. So there is some, but I don't know what's consistent across all the systems, at least in the level ones.
Yeah, it's a little different everywhere.
Yeah, and I would echo that as a level two. We have a designated person who does injury prevention, community outreach, and I know that she spends a ton of time going to outlying hospitals for education, especially in the rural areas. That's where she dedicates a lot of her time, because that's what's necessary. So I feel like we didn't get the credit that we probably needed. Because it just doesn't feel right to me, because I know the amount of time that she's actually spending doing that. So I feel like we mischaracterized it.
And that's a possibility, because, people are trying to, as best as we made the definitions as tight as we could,
Yeah.
people may go, I'm gonna put that in another, maybe that goes in another bucket.
Yeah.
But remember, what the take-home message, what you should see from this, even if we're off by a factor of 10,
Sure.
we're still low. So we need more funding so that we can do bigger and better things. So I think that's the take-home message there. Really good points. Okay, so we hit that. So then, here's the updated, what we came up with. The take-home message for level one was $10 million. The most significant cost was clinical medical staff. And the lowest cost, as we saw, was education and outreach. And then for level twos, it was about $5 million with the same highest cost and lowest cost. Yes, Dr. Medeiros.
Thank you, Dr. Ashley. I just want to make the comment as I heard people commenting on that they have full-time people and that they have people who feel like they're doing work. And two things I'd like to point out. One, we undertook this process not so much to identify what we thought you guys were not doing. It's older data, right? You mentioned that it was collected, could be before all of us were embarking on the ACS verification and having the positions that were required to have according to the Orange Book. And I think what's getting a little bit missed is what Dr. Ashley isn't saying that the commission is pointing out what you're not doing. It's saying, given the amount of funding that you have available to you, because it's so resource intensive for your clinical teams, your physicians on call pay, program managers, other program stuff, that what we feel like what's happening is the amount of dollars left over to put into injury prevention and outreach is a smaller pot, which tells the story to the legislators that in order to be most effective, we do need more money than the 7 cents on the dollar. Right? But I just wanted to make that point, be sure that people are understanding where we were coming from and what the point of collecting the data was, is to show that you're doing the best you can with what you have. There's just not enough dollars, pennies in the coffer to cover everything that we'd love to be doing.
And remember, it's average, these are averages across the state. So one center may have 1 or 2 outreach coordinators, but that gets diluted if you've got a center that doesn't or a few that don't. And then remember, it's cost and averages. So not everybody having the same resources can pull down the averages.
Dr. Ashley, can I add one more thing to that? If it was not a requirement in the Orange Book, it's not included in these numbers. So that could be the reason. You may have those costs that you're spending, but if it's not required for the level, it's not included here.
So now let's shift gears a little bit. This, like I said, is this just came out. I'm still pretty well versed in the 1s and 2s because I've seen it for so long. And again, this was, I believe, Regina, 2016, the study, the data that we did, we presented in 2018, but I think the data was 2016 or 17. So that data is, now we're already up to 2022. So it seems like it just came out, but it's getting dated as well. But now we have level 3 and level 4 data, which has been very helpful to us. And as far as we can tell, nobody else has this data in the country. Nobody's been able to reproduce this. So we think we're sort of leading the way here in Georgia. And again, we started the same process. We already had the template, so we pulled together our team again with the commission, with hospitals, our trauma program managers and so on. And based on the well-developed process from the 1s and 2s, we did the same process for the level 3s. So I won't go through all the process I just went through, but basically we replicated the survey that was specific for 3s and 4s in the requirements of the Orange Book. Okay, so they're totally different than, 1s and 2s. And then, as far as limitations of this, every study has a limitation, but, it is self-reported by each trauma center. So we are dependent on, like anything, like what's reported. Resources for optimal care of the injured patient was updated in 14. So this, we are purely using the Orange Book, so at least it's updated. And then several hospital systems about the time that this was going on, just the way Fate had it, were involved in acquisitions that sort of limited access to supporting documentation. So there's a lot of moving parts working with 3s and 4s in this type of healthcare environment, but we got it done. And this is, again, the methods here, and very similar to before. And in addition here, we had the random cost components. In other words, where the data was validated. This is the key. This is, it's not just survey data, even though we made the surveys tight. It's validated, and not every line, but at least financial, statistical rules of engagement. It follows the rules for financial evaluation, and that brings the data into line. So here we go. Here's the tables on this. Again, the summary, the take-home message is for level 3s. Again, we use the same categories over on the far left: the administrative and program support staff, clinical medical staff, in-house OR availability, and education outreach. Same format. And you can see for level 3s, the mean was $780,000 for administrative support versus $79,000 for level 4. The clinical medical staff were $920,000 versus 0 for level 4s. In-house or availability, they're not required to have that. So really, that was a wash. And then education and outreach, they're doing some, but if they had more dollars, they could do more. 13,000 versus 2,000. And let me go back. And so then the total readiness cost, level 3 mean was 1.7 million. That's at the bottom right there. And for level 4s, the mean was 81,000. If you want to just put one number or two numbers in your head, 1.7 million, 81,000. Now, breaking that down into seeing what the cost drivers are in each category. In the administrative category, the trauma program manager, not unexpectedly, for level 3 was 69,000. For level 4, 46,000. These folks usually wear multiple hats. So what I found out from talking to a lot of people, in a level 4, you may have 3 different jobs. So I think the costs are a little lower than for what you would assign specifically to trauma. Remember, these are trauma costs. Then again, looking at the program support staff, I know you can't read each line, but this is all those things we talked about, like physical therapy and occupational therapy, just all the different staff that you have to have. And you see the drivers here for respiratory therapy, really both for, really for the level 3s, respiratory therapy and level 4s, respiratory therapy were the main drivers. But then you see the things that are required for level 3, not necessarily for level 4, speech therapy, occupational therapy, physical therapy, and case management. Those are your big drivers in those services. And you can see why those would all be really heavily involved with trauma. Not too different really than the level 1s and 2s as far as the type staff that are required to take care of the trauma patient. Then if we look at clinical medical staff, these are your surgeons, your doctors. You have to have on call to cover patients that are tied directly to trauma. And again, for trauma surgery, that came out to the 3s, about $326,000. You see none listed for the 4s. They're not required to have those people on call. Trauma physician extenders, not a lot there. Orthopedics, 166,000. Let me go back. Those were sort of the trauma surgeon and orthopedics were the main drivers. There for the 3s, and again, not required for the 4s. And then for education and outreach, you can see, I don't know if you can see that, but all the numbers are pretty small. And then education and outreach, looking again at like the trauma medical director, the trauma program manager, the registrars, folks that have to have CME. Again, the numbers, the numbers are not real high, but there's a few dollars assigned to those categories. So the take-home message, level 3, 1.7 million annual cost. The most significant cost for them were the trauma surgeon staff, really trauma call pay. The lowest cost was education and outreach, which again is similar to the 1s and 2s. The level 4 centers, their average costs were 81,000. The trauma director was the most significant cost there, and then the TMD participation costs were the lowest. Were the lowest cost. So that's a whirlwind tour through readiness costs. That's all I got. I'll stop and see if you have any questions. Okay, Michelle.
Thank you, Dr. Ashley. I think that's just a fantastic overview of what we spend as healthcare systems on being ready for trauma patients when they come in. The commission has a few pieces that we would like to work on. We'll go into that later at another time, but we would like to hear from you what you think some of the focuses need to be for this administrators group, understanding where you are within your own facility, but then everything that you've heard today on our impact as a statewide system. So we would like to just take a couple minutes to hear from you all as to what you think should be some of the focuses of this group moving forward. Don't everybody answer at once.
I think one thing, so I'm in Crisp Regional, we're level 3, and in Fort Hill, Georgia, about 2 hours south of Atlanta. One thing I know that earlier the talk on the financial side of trauma is a big area that I think looking at the financial resources that are distributed to level 3, 4 trauma centers, if there's any money that you can either save or potentially gain, by having more of an expertise in that financial side of trauma, that really helps us. So if there's any support or education from the Trauma Commission, I really appreciate the TCAA grants that the 3, 4, again, like I can't stress that enough. I think the 1s and 2s, y'all, rightfully so, have a lot of resources and kind of already had that established for so long. I trained under Dr. Ashley at level 1 in Macon, and so kind of having had that perspective, and then coming down to level 3, just the financial breakdown of trauma is just a huge area that I think all of our 3 and 4 centers can gain from. So 1, I really appreciate that grant that the commission gave us. That's huge. And then 2, if we can kind of implement that, educate that. It's one thing to have the TCAA access now, but then really just diving into that financial side to learn more about how we can optimize our either savings or profits from.
Absolutely, that's great. That's great feedback. Thank you. And this morning was absolutely fantastic. Anybody else? Any other thoughts?
I definitely, the data shows that the biggest cost is that of the readiness is that for the physicians, that have to be on call, and that is definitely the case for us at Navicent in Macon. And I know, in past versions of this group, we talked about, is there a way for us to somehow affect that cost, especially for the things that there are just not a lot of those specialists to go around. So we all struggle with, flaps or various things. And so what can we do at this level to have some kind of shared savings? And I don't know what that looks like, but could we contemplate, that's something that I'm literally, there's emails in my inbox right now about, struggles of coverage that we're gonna have to meet. Either we're gonna have to pay locums cost or, or heaven forbid, that dirty D word go on diversion, so, I would put that out.
Okay, that's great. Anybody else?
I also wonder, as a most our apprentice, if there's some kind of, as we talk about diversion and capacity and, really wanting patients to stay in their communities and encourage, CBIs that are transferring that may not be appropriate. If there's some kind of technology that this commission could support regionally to keep patients where they need to be from a clinical appropriateness, I think that would be really meaningful and something that we can use the COVID kind of disaster as a resource going forward to solve some of that. So I think that would be really helpful.
Yeah, great feedback, absolutely, definitely something to consider.
And that is a great comment. My wheels are turning, and I hadn't thought of that, but what we had learned about, and I'm just taking this for example, because this is something we just did. There's many other examples out there, so I don't want to belabor the point, but with the subarachnoid hemorrhages that I talked about earlier, this would be a good thing if on the clinical side, if we decide in GQuip, or let's try this with a pilot study, then if we brought that and engaged all of you all here to know that this is going on, so then our clinical folks have support at the highest level and what it means, like this may help us all, both financially and from a clinical standpoint, and patient standpoint. I see the clinical part tying into this group to run things by you, to make sure you're informed and that you're supportive of what we're doing at the clinical front. So that's a great idea.
Well,
Thank you.
that's what they do after that, also run neuro services, and I'm tired of hearing neuro surgeons speak about them being woken up at 2 a.m.
You talked to mine.
I actually do know technology that exists to help that, so we can certainly help.
I would love to hear more about it.
That's great, thank you.
Damon?
Hey, Damian Scott, Emmanuel Medical Center. We actually have some of that in place with Augusta University. We've been doing, we actually started it to back up our ER, and we really couldn't get traction. And then COVID hit, and now we actually became a facility for COVID patients that were managed by us and Augusta University by telemedicine. So it can be done, but I would love to see some more projects around it. And I think you're right. If the administrators support it, that's half the battle. The other part is getting the physician buy-in, because we really struggled to get the ER docs to buy into it.
And if we can hear from and it be what you said, Damian, which is rural driven, not level 1 driven, but we've got to take it to the next level now that we accelerated everything because of COVID, because we had to. Now let's step back and think about what would make sense for a longer term, and then ensure that helps with our physician. And we could form our own as a state of expertise. I mean, there are ways to do it that wouldn't just lean on any one facility, but would really, I think, be able to help support the whole.
The state has done a great job with telemedicine in terms of reimbursement. Right now, you can get reimbursed from Medicaid at the same rate as if it was live. Medicare is not at that point. I would argue that it would make a lot more sense to pay the provider 125% of what they would for a live visit, because there is more effort. And I want it to be worthwhile to these larger centers to continue to do it. Right now, they're doing it because she's got a physician champion and she's a champion of it. But if that changes out, and if the reimbursement goes back to a pre-COVID where you're getting paid less, then it will end. And I think, go ahead.
No, go ahead, please.
I was just going to say it makes sense, because we know we're saving the system money, because we're not having to, spend, I don't know how much a helicopter costs to go to Augusta University, but it's a lot.
But they'll send it for you.
That's
That's
right.
right. I know what I'll send you. Only I have our helicopter in the state.
And I think this is
Oh,
where.
you
we-
just gotta brag, don't you?
Yeah.
We have.
This is the only people who would actually understand what that means.
But you were smart again. So that's probably work.
I think this is where we also, each of us in this room leverages our legislative partners. Many of us have those at the state level, and that is something that's definitely on the table. That there's lots of conversation about rates going back down to where we were before COVID. And, you know, we want to maintain that, whether it was the cost, whether it was the expanded scope of practice within our healthcare institutions. So there's things that we need to advocate for, and by understanding that and being able to talk the talk with our partners, I think that helps leverage us a little bit more as a system for sure.
I was just gonna go back to education and outreach, and it's clear, just based on the numbers, we don't have enough resources. But with the resources we do have, can this body come together, work more collaboratively and more strategically to actually, maybe by region, but, you know, work together on our educational efforts, and what are we doing? How are we using the ones that we do have? You know, is my, you know, education outreach coordinator, who I know is out there all the time teaching RTPVC courses and going to hospitals every week, but could he be doing it a lot more efficiently if we did it in groupings and we had, you know, set dates and got other folks all together? So we're not just going onesie twosies, and we're actually having a much more, you know, strategic approach to the educational side. I think if the big centers all committed in their regions to really help lead that, we could utilize our education resources a lot better and free up time where they can be doing more pointed education in the facilities that need extra attention.
Absolutely, no, that's a great point. Dr. Register?
So to echo off of that, what Dr. Ashley mentioned earlier in the opening session about March clause, I know that might be totally new acronyms for a lot of people in this room, but it's something that from especially the rural subcommittee out of the Georgia Trauma Commission, we've been talking about for probably 6 months now, rolling it out. March clause is basically it's a clinical training course, much like ATLS or TCN for, you know, whether it's physicians, it's ATLS, the nurses have their own, EMS have their own, but we don't have anything that everyone works together on the same page. And so exactly what you were talking about, kind of how do we get that collaboration between the level one that's going to ultimately be the final destination for a lot of our trauma patients in rural Georgia, but they've got to go from on-scene EMS to the rural center, whether that, and a lot of times that's not even a trauma center, that's just another ER, you know, that doesn't participate, you know, isn't a designated trauma center. So March Pause is kind of our hope is the solution to that. It's a central training course that maybe it's teaching a lot of the same clinical information, but it's an arena that we can all do it together. It's not separated by physician versus EMS versus nursing. And so we really feel that that is going to be a big step in kind of this collaboration of more of a flowing system of trauma care throughout the state, rather than kind of how it is now, these separate different arenas like pre-hospital and then the rural center and then the level one. So I hope that y'all hear a lot more about that. We're planning on talking about it at like the GHA meeting coming up. But just for y'all to kind of plug that in your ears. So if you hear March Pause again, that's the ultimate goal, is for us to be able to collaborate together between the rurals and the level ones.
Absolutely. Any other thoughts? This is really about you all sharing today, not so much what.
One other comment that I would make is, you know, I think this group could also spearhead the hardwiring of things back at our local facilities. Not that we aren't already, but I definitely think there's more opportunity, you know, as we turn over in our various, you know, positions and newcomers come in. How do we make sure that all the great work that's being done, that's coming out, isn't lost? You know, I think about earlier the presentation about infrastructure and our quality metrics and how we've all taken a hit, and that's not specific just to trauma. You know, our non-trauma quality metrics have also taken a hit over the past few years. And I think part of that is just based off of, we were having people do some extraordinary things pre-COVID that was driving those numbers down, getting our quality good. But then once those people had to be redeployed or, any number of things, we saw that we weren't able to sustain quality. So from an administrative standpoint, how do we support and hardwire those things so that regardless of who's in this room, we continue to move, the needle forward?
And how do you even do it at the staff line level? I mean, what we're seeing, I'm sure everybody in this room is seeing, is the massive turnover of your frontline staff in your emergency department. If you've got, 20-30% of your staff's a traveler that's never gone through your trauma nurse courses or never had the good trauma training, it's a little scary, So what does it look like? What's the basics of it even look like to maintain trauma competency in today's critical staffing climate?
The landscape is shifting.
It is, yeah.
Angela?
Yeah, I would just say that, I know no one really wants to talk about the dirty D word, but we need to talk about it. Because this is the first state I've ever lived in that it was that easy for someone to go on diversion. And, we refused to go on diversion at Northeast Georgia Medical Center, and we were getting trauma patients from all over the state. It was the right thing for us to do, but we got a lot of pressure from Hall County and from others, because if everyone's on diversion, no one's on diversion. And I felt really bad for our pre-hospital partners. They were going any and everywhere. Where are we going to go? And so, I would just like to see a little bit more action surrounding that. We got our governmental partners, our legislative partners involved in that, but all we got was a really nice statement letter that came out of the work that was done, and saying everybody knows what EMTALA is. Well, of course we do. But at the end of the day, we've got to have a shared commitment with each other in regards to, every day I sit on the GCC board, site diversion, ER diversion, trauma diversion, and there was almost every single trauma center on diversion at one point. And that was at the height of COVID, and I knew that exacerbated the problem. But we need to talk about it, and we need to kind of come together as a team. And what are other states doing? I know I came from the state of Virginia, and diversion was a naughty word. We just didn't do it. Not saying we never did it, but at a level 1 trauma center, we just did not do that. And so I'd really like to understand some of that, and maybe some of you can actually help me with that. But that's just some of the things that was a big source of frustration. I know Gwinnett was just as frustrated as we were. And so I would like for us to tackle. That's what we're here for. We're administrators in the room. We're decision makers.
Absolutely.
So I just think that that's the kind of stuff that we should be in here doing.
And it's
Besides
COVID
my
now,
duties.
but it'll be something else.
Absolutely.
Soon, there'll be something
Absolutely.
else that comes up.
I'd like to point out on the opposite side of the coin from that, the level 4 perspective of diversion. During COVID, I actually, we don't have trauma surgery. I actually had a spleen laceration in my ER that we could not get out. Memorial was on diversion, trauma diversion for the first time in my career that Memorial had been on trauma diversion. And Augusta was on diversion, and where do we go? We were trying Florida. We were going out of state, and finally Augusta took our patient. But it's very frustrating from our standpoint as well. And if there was some type of system to where there's always somebody within a certain region that this process can, these trauma patients start sitting there bleeding out somewhere.
I think your patient was our poster child for coming to the table and pulling
The
that
spleen
CEO's
laceration.
call together. Cause I just couldn't sleep at night thinking that we potentially had somebody bleeding to death in somebody's ER. And that's just a never.
Ultimately, we have the work that we need to do within the commission that has been longstanding from the time we started, our finances, our funding, those types of things. But then we will have these things that come up that showed the deficiencies of healthcare over the last couple of years and the things that we've shared. So this has been absolutely great feedback. I know others were taking notes, so I didn't have to write everything down. Couple of next steps. One, you have a piece of paper in front of you that actually breaks down our funding. We knew we were not going to get to that today, but we wanted to go ahead and share that with you. That is step 2, where we'll need to, not me, but more like Dr. Ashley and others will give a more expert deep dive on that information and what it means for you. So that will be coming shortly. We will need to decide on a next meeting I will probably send out a survey monkey. I'm looking at Gabby and Liz to be able to gather a little bit more of what you're thinking. Mornings, evenings, days of the week, probably looking towards the middle to the end of April. Our next commission meeting is in May. We would rather not be so tightly aligned, so tomorrow's our commission meeting. We'd rather not be so tightly aligned with that if there are things that this group needs or recommendations, that we have to do it right immediately. That's just, we need some time from a commission member standpoint to have that information, to understand it, filter it. So we'd like to move it back just a little bit. So you'll be receiving something there. I'll talk to Liz and Gabby what that needs to look like. But keep those minds, keep your stuff twirling, whatever's in your head that you're thinking about that this group can add value to. Everybody brings a unique focus. We're all very same, but we're also very different. We have different needs. So please make sure you're thinking about that. Again, thank you so much for your participation today. It was outstanding. Lots of great conversation, and really look forward to working with you all in the future. Thank you very much.